Okay. All right. So this afternoon, we're going to discuss the evaluation of the anemic patient. And because anemia is a very common condition that we see in patients, it's one of the very first lectures in this series of lectures. And it's a lecture that you come across, or it's a topic or an aspect of medical care that you'll come across again and again. So we do emphasize that one pays a lot of attention, because when we come later to talk about other hematologic and non-hematologic conditions, you will see anemia is a very common feature. So we will review the definition of anemia. That's something we like people to have very clearly in mind, what anemia is. So I will go through it very carefully. And then we will go through the evaluation of an anemic patient, the clinical features. Let me try and move this. Are you seeing this the other part of the screen that is visible, showing the attendance?
No.
Okay, so that's fine. Okay, so we will review the clinical features, that's the history and physical examination that are associated with anemia, and also the investigations, laboratory and others. All right, I like this class to be as interactive as possible, so please, I may not be able to see my chat box because I'm using my full screen, but people are encouraged to answer when I ask a question. So the first one is anemia a diagnosis? Anybody wants to tell us whether anemia is a diagnosis? Yes, Lavin?
Anemia is not a diagnosis. It's not.
Yeah. Yes, that's quite correct. That's very good. It is not a diagnosis. So whenever you're asked what is a diagnosis in this patient, please never say anemia, because that is not a diagnosis. So how do we define anemia? Yes, somebody else, give it a try. Yes, I may call on people that I see here. Val Wambani. Val Wambani, unmute and tell us how we define anemia. Or whoever else wants to help her. Surely there must be somebody. Steve Ogwang. You're going to be a very dull class if you're not going to be participating. Anybody? You've done this before. Surely there must be somebody. There's no harm in trying. Okay, we'll move on then. Non-hematologic. So examples might be iron deficiency anemia. That may be a condition or is a diagnosis. An anemia of chronic disease, such as somebody who has a chronic renal disease or chronic cardiac disease. Very often they will present with anemia. All right. And because of this, even a mild asymptomatic anemia should be investigated so that this primary problem can be treated before it becomes worse. It is detected early and treated early before it becomes worse. So even if somebody has a mild anemia, they have no symptoms, it was an incidental finding, you must always investigate and find out what is the cause. So the definition of anemia, again, you should have done this in your earlier class. And anemia is defined as a condition where there's a reduction in the hemoglobin concentration. So I have highlighted the hemoglobin concentration in red because a lot of people come and tell us about red cell counts, hematocrit, whatever else, but we prefer to use hemoglobin concentration, and I will tell you why. So where the hemoglobin concentration is reduced to below the lower limit. Again, it is not below just a reference interval. As you know, a reference interval has a lower limit and an upper limit. Therefore, we define it as below the lower limit of the reference interval. Who's talking, please? Can you mute? There's somebody there who's making a lot of movements and talking. They can mute, or the class rep can mute them. So below the limit of the reference interval, and this is for a specified age, sex, and geographic location. We know that the definition is age specific because we know for children, the hemoglobin, the reference interval for hemoglobin varies according to the age. So sex, again, we know for males and for females, it is different. Geographic location, because we know when you're in a higher altitude as compared to at a lower altitude, the hemoglobin level will vary. And hemoglobin, I said, is preferred because of accuracy and reproducibility, okay? So that's why we prefer using hemoglobin concentration. The hematocrit, or the packed cell volume, is always reduced when your hemoglobin is reduced. So if you have a low hemoglobin, your hematocrit will also be low. The red cell count is also almost always reduced. And you can see I've put almost always reduced. You will see sometimes, especially in maybe early iron deficiency anemia, even though you may be having an anemia, the red cell count may still be within normal, okay? So that's why we do not use red cell count to define whether somebody is anemic or not. And then in women, the men, we usually use 13 grams per deciliter, or 13.5 is also used quite often. And for women, the lower limit is 12 grams per deciliter. So this definition is important for you because that's what we want you to be using whenever you're deciding whether anemia is present or not. Okay, now here is a quiz, and I hope you'll be a bit more active now. An adult male was reported to have the following partial counts, okay? Joshua Karanja, can you please read this for us? Can you unmute and read this for us? Class rep, do you have a class that is interactive, or you're usually just silent there? Class rep, who's class rep? Sorry? Naveen, yes, go on.
It is always interactive.
Then why are people just quiet? Huh? I think you're going to be a very dull class, unlike the others I've taught. Yes, please go ahead. Okay, go ahead. Is it Bashir who's going to read it?
Okay. An adult male was reported to have the following partial blood counts: HP level of 5 grams per deciliter, hematocrit of 30%, and the RBC of 4 power 12 per liter. Comment on these values.
Thank you, Bashir. You want to try and comment on these values?
Okay, the HP level is severely reduced. Hematocrit is within normal range.
Not
27
quite.
to, okay. So
Hematocrit,
it's slightly reduced.
that's reduced, yes.
And then RBC is reduced.
Okay. Anybody wants to comment? Any other comment? All right, we shall see now. Keeping these figures in mind, do you remember the relationship between hemoglobin, hematocrit, and the red cell count? Who remembers? What is the relationship between hemoglobin and hematocrit? Yes, Lavin?
Hemoglobin
Anybody?
is a third.
Yes, Sharon?
Hemoglobin is a third of the hematocrit's value.
Very good. Okay, so hemoglobin is about a third of the hematocrit. Now look at those figures for hemoglobin and hematocrit. Can you comment? What do you think about that? Go ahead, Sharon.
The hemoglobin level is low because it's below 10.
Yes, but what
Instead,
look at the hemoglobin and hematocrit. Can you comment on that relationship? You've just told us hemoglobin is a third of hematocrit.
so for you to get the hematocrit, you multiply the hemoglobin level by 3, which is going to be 15. While here the hematocrit is 30.
Okay, so they are quite off, isn't it?
Yes.
So this value is way off what is expected. So you suspect there's probably an error. We don't expect the hematocrit to be 15 on the dot. It might be 14, it may be 16, but 30 is way off. For a hematocrit of 30, we'd expect a hemoglobin of around 10. So that tells us that there's some sort of error in this determination, okay? So that's how you should always interrogate your results. And then red cell count is usually what in terms of comparison with hemoglobin? It's usually a third of the hemoglobin. And we can see here that the red cell count is almost normal, and yet the hemoglobin is very low. So if one was to comment on these blood counts, one would say that they are way off and they do not look accurate, okay? So that was a quiz to sort of wake you up that you must always be looking at your results and comparing and interrogating them. So that's what we've just talked about. The packed cell volume or hematocrit is approximately hemoglobin times 3, whereas hemoglobin is about red cell count times 3. And these are rough estimates to provide a guide in case there are errors in your blood counting equipment or in your results. So when we look at the mechanisms of anemia causation, if we remind ourselves, anemia either comes about as a reduction in red cell production in the marrow, or increased red cell destruction, and those are the hemolytic anemias, or you have red cell loss from circulation, as you may find in hemorrhage or splenomegaly. And in splenomegaly, the red cells are sequestered in the spleen, and then they will undergo premature destruction, okay? So if we look at any of the mechanisms, or when we talk about anemia causation, they will fall under any of those. And you may have one or two, more than just one cause coming to play when in the causation of an anemia, okay? So this is just to remind you of the reference intervals. And if you remember, it differs upon, depending on the altitude. So if I was saying this is at Nairobi, then if you are at the coast, you'd expect some reduction in the HB, hematocrit, and red cell count, because those are related to each other. Okay, and you can see the male and the female differ. And then for children, I haven't shown the children's reference values here, but they also will differ. The MCV, MCH, and MCHC, those tend to be standard or the same for males and for females, all right? So those are the parameters that will be the same for males and females. You will be expected to know offhand at least the hemoglobin, hematocrit, MCV, and MCH, all right? Because we will be giving you things to interpret, and we expect, because these are very common, very important parameters, that these will be available to you in your head. We do recommend that every lab sets its own reference ranges, so you may see some variation. Like for male, you may see 13 to 17. For female, you may see 11.5 to 15.5 or 16. Again, those are minor variations you may find depending upon whichever laboratory and whichever physical location that one is talking about, and what kind of equipment was used to determine the reference interval. Okay, sorry. So let us now look at the manifestation of anemia. How does anemia present? Or what are the signs and symptoms of anemia? How the anemia will present will be determined by how much there is a reduction in oxygen carrying capacity of the blood. Because we know when the red cells are reduced and the hemoglobin, which is in the red cells, is the one that carries the oxygen, there will be a reduction of oxygen carrying capacity. And because of that, there will be certain symptoms and signs we will find. And the second thing that will determine the manifestation is the degree in the rate of change of blood volume. Whenever there is the reduction in the red cell mass, there often, especially with chronic anemias, there's a compensatory increase in the plasma volume. So the plasma volume will increase to compensate for the reduction of the red cell mass. And this you will see especially manifest in patients who have a chronic anemia, because there's been that time for those changes to take place. As opposed to somebody who has an acute blood loss. If somebody has acute blood loss, there is very little time for the plasma volume to change. And therefore, somebody who has acute blood loss will have more severe signs of anemia as compared to somebody who has had this anemia developing over time. The rate of change, the rate of development of those changes, and that is now what I implied by saying acute blood loss as compared to chronic blood loss or chronic anemia, where there's been time for these changes to occur. The capacity of the cardiorespiratory systems to compensate for the anemia. So if one has already some underlying cardiac disease or underlying lung disease, there's reduced capacity for the lung or the heart to compensate for the anemia. And therefore, somebody with those kind of conditions will present at higher, relatively higher levels of hemoglobin as compared to somebody who is perfectly normal. And then the associated manifestations of the underlying condition. Remember, we said anemia is not a diagnosis. So the anemia the patient is presenting with might be due to kidney disease. And therefore, besides the features of a general anemia that we will see, there will be also features due to the kidney disease. So if they're having low urinary output, that might be another feature that we'll be able to pick up in our history and our investigations. So you can see that how the anemia will manifest is determined by those factors. And therefore, whenever we are evaluating a patient with anemia, we have these factors in the back of our minds to determine, is this a rapidly developing anemia, or is this an anemia that has developed slowly over time? So what are the symptoms of anemia? Now, the symptoms are generally not very sensitive, nor are they very specific. And you will see, for example, pallor, which is one of the major signs we look for in anemia, is not only seen in anemia. If somebody is walking around out in the cold, they may have pallor again because of the vasoconstriction that may be seen. Or if somebody gets a vasovagal attack and they get shock, again, they will tend to present with pallor, even though they may not be anemic, they may not be anemic. And often, these symptoms don't help us differentiate between the types of anemia. So you will see when we come to talk about breathlessness or dyspnea, that doesn't tell us what is the underlying cause of anemia. It just tells us that anemia is present. The symptoms may also reflect the compensatory responses to tissue hypoxia and will usually develop when the hemoglobin falls below the patient's baseline. And when the fall is quite great, then the symptoms tend to be more pronounced. So the severity of the symptoms will depend on how quickly the anemia is developing and how severe the anemia is, and the cardiopulmonary reserve, those factors that I said that will determine the manifestation of the anemia. So when we come to talk of the symptoms, there are quite a number of symptoms. As you can see, these are quite a long list of symptoms, but there are some which are very common, and we will look for them all the time, such as the general fatigue. A patient will say they're feeling very tired. They don't feel like getting up. They feel lassitude or laziness. They feel weak. They don't feel like they have their energy. If they're trying to push something or to do their normal work, they feel they're not able to do the normal work or even the normal activities associated with living, such as like getting up, walking, sitting up, stretching. They may feel weakness even doing those. They may feel dyspnea or breathlessness, and this will be exaggerated with exertion. So if you tell them, walk to the end of the corridor, walk quickly, they will feel they're very breathless. Palpitations, they will feel the sensation of their heart beating in their chest because of the anemia. I've mentioned dizziness. They may stand up, they feel faint. Some may even faint, which is syncope. They may have fainting associated with this dizziness. And headache. Very many people with anemia will complain of a constant throbbing headache. Tinnitus, which is the ringing in the ears. Lack of concentration. If many times when children are anemic, the teacher may be the one who will notice, and they will say, this child does not seem to concentrate. They look drowsy all the time. They are unable to grasp what is happening in class. Visual abnormalities. Blurring of the vision is very common. Patients may see this. Insomnia or lack of sleep. They may also have drowsiness as well, when they are very drowsy, when they should be awake. Leg cramps. And when it's getting very serious, they now start having puffy face and swollen legs as part of the symptoms. Remember, symptoms are those that the patient says they're feeling. So the symptoms is what the patient will come and tell you. And these are the features that they are detecting. Then the signs of anemia, there are the general features or the general signs. Pallor is the most common, especially with severe anemia. A mild anemia, you may not be able to see pallor. And as you know, pallor is pretty subjective. So we're looking for pallor in the mucous membranes of the conjunctiva, the tongue, the palms, and the soles of the feet. If these are, if they're not pigmented, sometimes you may get people with very heavily pigmented palms. But those are the areas where we look for pallor. Bounding pulse, the pulse when felt may have a sort of bounding, nature, that it feels like it's, a large pulse, okay? You feel that bounding nature. You may be able to detect edema or puffiness of the face, pedal edema. And when you go into the wards and maybe you started rotating in the wards, you will have some of your clinical rotations where how to detect these signs will be shown to you, the proper way to detect these signs. Then if there is shock, especially with the severe anemia, there will be hypotension or low blood pressure, tachycardia, pallor, tachypnea, and diaphoresis. Okay, so those are some of the features that we see, and they're general features. They will not tell you this anemia is due to kidney disease or heart disease or severe iron deficiency. These are why I've called them just general signs of any anemia. Then we have features which are seen in addition to those general features of anemia. These are additional features that may indicate a specific etiology or a specific type of anemia, all right? So if it is iron deficiency anemia, we may see koilonychia, which is spooning of the nails, and I will show you a picture of that. A patient may complain of pica. Pica is where patients want to eat soil or clay, and this is some reaction to the lack of iron. And so a patient may tell you that, for the last several months, I've been having this desire to eat the soil. Glossitis, which is a smooth tongue, which can also be seen in iron deficiency. If it is an anemia due to vitamin B12, they will have some neurologic signs, and you will come across this when you talk of the megaloblastic anemia. And then the tongue will also be beefy, meaning that it looks very red. Again, when you have that very red tongue, when you're looking for pallor, it may not give you a good indication of pallor because that tongue seems to be very red and inflamed. You may have in a hemolytic anemia jaundice, that is the yellowness of the mucous membranes, especially the sclera of the eye. You may see skull bossing. I'll show you an image of what skull bossing looks like. And another sign you may find is splenomegaly. You may find an enlarged spleen, and this may point to a hemolytic anemia. If it is due to sickle cell disease, you may find dactylitis, which is the swelling of the fingers. Patients with sickle cell disease also tend to get hip joint deformities and therefore have abnormal gait and pain in the hips. They may also have chronic leg ulcers. And then in some other anemias, like Fanconi anemia, you're going to come across it. It is not a common anemia. It's a fairly rare anemia, but in this, it's a hereditary type of aplastic anemia, and they do have some skeletal deformities. So that by looking for other now specific features, you may now come to a conclusion or some idea of what might be the specific type of anemia that you're dealing with. And this is just to show you the scleral jaundice. You can see in the eye here, with the eye, the sclera looks yellow. This nail shows you koilonychia, where the nail is spoon-shaped, or there is indentation of the nail. And in addition, you can see that there is some ridging. You can see that the nail has abnormal ridging. Then this is Fanconi anemia, a patient with Fanconi anemia. And if you look at this right thumb, you can see that the right thumb is showing, this is what we call syndactyly. That means that it looks like there are two abnormal thumbs that are joined together. Okay, so that's one of the skeletal abnormalities we see. The boy below has skull bossing. This is where the forehead and the back of the head seems to get some prominence, so that the forehead seems like it's protruding. It is more prominent, and the cranium also looks abnormally shaped. And this is a feature that we see commonly in some of the hereditary or chronic long-standing hemolytic anemias like sickle cell anemia. Then you can see here, this tongue is sort of looking smooth and, you know, sort of inflamed. So this is glossitis. And this is a feature that you might see in iron deficiency, where the papillae, or the small little projections on the tongue that we expect, are absent, so that the tongue looks very smooth. And then this is a child with swelling of the fingers and the thumb. And this swelling tends to be very painful. This is what we call dactylitis. And this is what we see in sickle cell anemia. So by seeing some of these features, it may tell you what kind of anemia we are dealing with. And then there are features due to underlying condition. You might see melena stools. This is when you have, especially if you have upper gastrointestinal bleeding, like peptic ulcer. Then there's hematochezia. This is when you see fresh blood in the stool, and you may find this in colorectal cancers and other conditions such as hemorrhoids, etc. Then organ disorder, you might find you have an enlarged spleen, you have kidney abnormalities, cardiac. So one would look at for these, which may point to the underlying condition. I think there's somebody who's got their microphone on or something. That's why there's an echo. If you could all please mute yourselves so that we do not have an echo. All right. And other neoplastic diseases, like if somebody has leukemia, there will be the underlying features that we may see with that. So knowing all this, when you come to examine and take a history in a patient with anemia, you have to make sure you try and get those historical aspects. So whenever we evaluate an anemia, we look at the clinical features, and I've said the history and the physical exam, those are the clinical features. In the history, you look for common symptoms of anemia or the general symptoms. You also look for specific risk factors for a particular anemia. For example, if a patient says they are strictly vegan diet, then you know this might be a patient who might have vitamin B12 deficiency, okay? So you look in your history for specific risk factors. Then you look for the symptoms of anemia itself, and I gave you the general symptoms of an anemia, and then also symptoms that may reflect the underlying disorder, like if I said there's jaundice, then you know that it might be a hemolytic anemia. So in your history, you have to take a good and careful history. In your physical exam, you look for the general features of anemia that I have highlighted. And then you also look for specific features of particular anemias. And I gave you some examples like skull bossing or cholinecia, etc. And then looking for the underlying disorder, again, in your physical exam. If you think this patient may be having a stomach tumor, you'll examine the abdomen very carefully to see if you can feel any masses in the abdomen, which may indicate that there might be a tumor. So a good history and physical examination is key to guide you in your tests. So when we come to tests, there are hematologic tests, which will identify and determine the type of anemia that is present. And then there are the other tests to determine the cause or the specific nature or the specific diagnosis causing the anemia. So that is the three-pronged approach that we use when we are evaluating an anemia. So let's go back into the history. When you go to the wards, as you start rotating, when you find a patient with anemia, take a careful history. And in that history, you will be looking at the onset. When did these symptoms begin? How long they have been there? This will help you know, is this an insidious development of anemia? Meaning, is it a slow or prolonged, slow course of disease? Or is it acute? Acute, like you might get in an acute blood loss, where the patient will tell you, 2 days ago, I was perfectly well. Then suddenly I started feeling very dizzy, etc. So that when you ask them now, you'll be seeing what happened acutely in that period of time. And whether these symptoms started from a young age, again, that might point to an inherited condition, as opposed to something that started at adulthood, which may point more to an acquired condition. You will also carefully look into the medications being taken. There are medications that you will come across that may predispose a patient to blood loss, such as the non-steroidal anti-inflammatory drugs, and that may explain why your patient is anemic. There are other medications that may suppress the bone marrow and prevent red cell production. Yet other medications may be associated with the development of hemolytic anemia. And therefore, medication or drug history is important. Family history, again, you're looking for hereditary conditions. Occupational history, some people may be working in certain occupations where they may be predisposed to develop anemia. For example, in the benzene industry, those people working in that industry are more prone to develop a certain type of anemia known as aplastic anemia or hypoplastic anemia, where there is bone marrow failure. People who work with organic organophosphorus pesticides, again, may be predisposed to developing certain types of anemia. So that occupational history is important. Dietary history, again, very important, especially in children who often will have a poor diet. Again, people who are vegans, etc. Change in stool habits, again, looking at that. If the stools are tarry or dark, very dark, it may imply there is blood loss occurring in the GI tract. Again, may point, changes in stool habits may point to other conditions such as colorectal tumors. Menstrual reproductive history in females, very important because females of reproductive age are very prone to developing iron deficiency anemia. presence of absence of cough, fever, bleeding, and the bleeding can be epistaxis. That should be S at the end of epistaxis, bruising, purpura, etc., limb pains, paresthesias, urine color change. If the urine is red, it may show that there is obvious bleeding, or it may change to Coca-Cola urine, that is very dark urine, which we may see to tell us that there is this is hemoglobin that is present in the urine. And check for symptoms of underlying disease, anything to suggest chronic renal failure, anything to suggest malignancy, etc. So you can see a very comprehensive systemic inquiry is important, because the patient will not of their own, or may not of their own volition, tell you, oh, I am having A, B, C, D. It is for you to inquire in your history. Has there been any change in your bowel movements? Do you get constipation, for example? Do you get diarrhea? How does this look like, etc.? Okay, so that is a good comprehensive history. Then we have mentioned the physical examination, and you will do the good physical examination, doing it as you have been taught, all the parameters, the temperature, measuring the pulse, the nature of the pulse, the heart, the cardiovascular system, respiratory system, abdominal exam, central nervous system examination. So you combine the two, the history, physical examination, it gives you some sort of impression or clue. And then next will come the investigations. And I will dwell more on these investigations because these are in the laboratory and the others that are supposed to help you clinch the diagnosis. So the two principles: one, you want to establish whether there is anemia present and the type of anemia. Secondly, now you want to determine the cause of this anemia. And as always, investigations should be stepwise. And we start from the simple, routine, or sometimes even called screening tests, to the more invasive, expensive, and more elaborate tests. So using our history and physical examination, those clinical features, to help us determine which type of tests should be now performed. So for all, we usually do the test to establish the presence of anemia. This will be your hemoglobin. It will tell you whether anemia is present, and the severity, the same as your hematocrit or packed cell volume and red cell count. And a severe anemia is that anemia where the hemoglobin is below 8 grams per deciliter. Moderate is 8 to 9.5, and a mild anemia is that where the hemoglobin is 9.5 to 13. This is 13 for a male, it would be 12 for a female, okay? So those are how we grade the anemia. We will also look at the other parameters, the red cell indices, mean corpuscular volume, and MCH, that will tell us the morphologic type of anemia. And I remember we taught you about the microcytic, the macrocytic, and the normocytic. So using the HB and the MCV, that will tell us the morphologic type of anemia. The red cell distribution width, this is another parameter that is there on our blood counts, and it does tell us whether there is anisocytosis present. And if you remember, anisocytosis was the variation of the red cell size, okay? So variation in red cell size is what we call anisocytosis, a useful parameter. And then we look at the white cells and the platelets. again, because the cause of the anemia may be related to these. For example, if you have a leukemia, your white cell count will be high and your hemoglobin will be low. And therefore, that will tell us, we will see that the cause of anemia might be due to, is likely due to the leukemia. Then the other very important test is the peripheral blood film. The peripheral blood film is a test where we look at the morphology of the blood cells. So we will look at the morphology of the red cells as well as the other blood cells. This is an important step because this will tell us when we correlate the blood cell counts, the blood counts to the morphology, it'll give us a more complete picture. So if my blood count showed me I had a microcytic hypochromic type of anemia, and I looked at the morphology and I saw the red cells were microcytic and hypochromic, it will help confirm the features that I'm seeing. Then there is the reticulocyte count. And here I have a question to see if you are still all there. So what is the significance of our reticulocyte count? First, let's start. What is our reticulocyte? Can somebody tell me what our reticulocyte is? Yes, somebody unmute and tell me what is a reticulocyte? Yes.
They're immature nucleated red blood cells.
Okay, that's a very good attempt. They are immature red cells. However, they are not nucleated. They do not have a nucleus. A nucleated red cell is called a normoblast or erythroblast. Okay, a reticulocyte does not have a nucleus. However, it has RNA within it. Okay, it has RNA. And to do a reticulocyte count, we usually either can use special stains, which are known as supravital stains. And the supravital stains will help us identify these reticulocytes. When we look at a peripheral blood film that is stained with Leishman stain or with MGG, we will see what is known as polychromasia. Polychromasia is what we will see when we have an increase in reticulocytes. Okay, so a reticulocyte is a juvenile or immature red cell. It does not have a nucleus, however, it has RNA. So what is the significance of a reticulocyte count? Does anybody know? If I have a rise in a reticulocyte count, what might it signify? Yes, Robin?
It shows increased rates of hemopoiesis.
Very good, yes. So the reticulocyte count gives you an indication of the hemopoietic activity of the bone marrow, all right? Therefore, if I have an anemia and a raised reticulocyte count, it tells you that your bone marrow is working very hard to try and replace those cells that are being lost, okay, or the deficiency in red cells, okay? And it tells you that the problem is likely not to be with the bone marrow, but could be somewhere else, like it could be a hemolytic anemia, where you're having your red cells being destroyed prematurely. And if the reticulocyte count is low, what might that tell you? Yes, if you have a reticulocyte count which is low and you have an anemia, what might that tell you? Yes, anybody?
Yes, the problem could be with the bone marrow.
Very good. It tells you that there is a problem with the bone marrow production of the red cells. so that if you have iron deficiency anemia or folate or B12, you have your deficiency anemias, the reticulocyte count is usually low because the bone marrow does not have sufficient hematinics to produce red cells to replace those that are dying off, all right? So that if you have a low reticulocyte count, it tells you there's decreased red cell production, such as you may find in your deficiency anemias, or when the bone marrow has been replaced by abnormal cells, like we see in the leukemias, etc. Okay? So that's why whenever you have an anemia, you must always do a reticulocyte count. It's an important investigation. Okay. So let's go on. So this is just a chart to remind us of how we classify the anemias, so that as you're investigating these anemias, you have some idea as you're finding the results, how you use those results to help you come to the cause of anemia. So we have the anemia, we have our red cell indices, which are the hemoglobin, MCV, MCH, red cell count, hematocrit. We have our blood film and reticulocyte count. So those are the very important initial preliminary tests we do, TBC and peripheral blood film and reticulocyte count. So if we see the MCV is low, that means that you have a microcytic anemia. That could be iron deficiency or any of the others causes of a microcytic anemia. And you already have all these in your notes. If the MCV is normal, that is anormocytic anemia, there's a whole host of causes ranging from a hemolytic anemia, anemia of chronic disease, hypoplastic or aplastic anemia, or bone marrow infiltration by neoplastic disease, etc. Okay, and you will know by doing your reticulocyte, if the reticulocyte count is high, that is more likely going to be a hemolytic anemia, because in all the others, the reticulocyte count will be low. Then when you have a high mean corpuscular volume, it tells you that it's either a megaloblastic anemia or it is a non-megaloblastic anemia, okay? So by doing our preliminary tests, we are able to come to some fairly good idea, because our blood film will also, if it shows us sickle cells, then we'll know, oh yes, this is now sickle cell anemia, etc., which is most likely. So once we've done these preliminary tests, and together with what we found in the history, we now can know which other tests to perform that will help us clinch the diagnosis. So now we can take a little break and we can now have a look at some peripheral blood films. Now I have my pointer on the one on your extreme left. Anybody wants to tell me what abnormalities I am pointing to here? Can you see my pointer? Anybody know what abnormalities these might be in the red cell? Yes? Somebody?
Sickle cell anemia.
Very good. These are sickle cells. And up here you can see this is what? What is this? This is a nucleated red cell. And that's what we call a normoblast or erythroblast. Okay? What about on the right? What do we see? Anybody with any idea? What shape are these red cells? Yes? What shape are the red? Yes, okay. These are elliptocytes, all right? These are what we call elliptocytes. And these you can see in which kind of anemia, because there are very many. What kind of anemia do you see very many elliptocytes like this? In hereditary elliptocytosis. Some of them, like this one, is oval. In an ovalocyte is one which is now more plump than an elliptocyte. An elliptocyte is very elongated. And this is quite different from a sickle cell, because a sickle cell has pointed edges, and you can see the ends are very pointed, whereas an elliptocyte has rounded ends, okay? And then in this one, now we see the cells are more oval shaped, all right? You have now more oval shaped, like you might see in hereditary ovalocytosis. And here, what abnormality on the right can you see in the bottom right? These ones that I'm pointing to. What cells are those?
Spherocytosis.
Very good. Those are spherocytes. Okay. You can see they're microspherocytes in that they're smaller. This is a normal cell here. It has normal centropala, but these are microspherocytes. They're smaller and they don't have an area of centropala. They look as if they're hyperchromatic. All right. What do we see up in this micrograph? Up at the top left-hand side? Yes?
Parasites?
Yes, these are red cell inclusions. These are parasites. Which parasite?
Malaria.
Very good. Malaria. Very good. Malaria falciparum, Plasmodium falciparum, which is a malarial parasites. What about on the right, the top right? What are these cells?
Target cells.
Very good. When do we see many target cells like this?
Thalassemia.
Very good. Thalassemia. Which other condition as well? Do we see many target cells like this?
Iron deficiency.
Yes, you may see a few, not as many as what I'm seeing here. You may see some in iron deficiency. Very good. When else?
Liver disease.
Liver disease. Very good. There's also another condition. Not too much. Okay, you may see in splenectomy. Yes, you may see them in splenectomy, but not too much. Which other disease do we see? Lots of target cells. And this slide was actually taken from that. I can see sickle cell anemia. Very good, sickle cell anemia and hemoglobin C disease. All right. One of the hemoglobinopathies, hemoglobin C disease, you see very many target cells like that. So target cells are very common in the hemoglobinopathies and those other conditions that you've also mentioned. Okay, so let's go back to the left. What am I seeing? What are these?
Bite cells.
Yes, they're what?
Bite cells.
Not so much bite cells, no.
Schistocytes.
Okay, they are red cell fragments, schistocytes. And these ones look like what? I know some of you write them. Yes, helmet cells. Very good. Yes, I think those are motorbike riders, eh? They know what they look like. Okay, so this is a fragmentation type of anemia. This is an anemia where there's red cell fragmentation. So these are, you are seeing red cell fragments or schistocytes and helmet cells, all right? Anybody know any conditions where we might see fragments like these?
Microangiopathic hemolytic anemia.
Okay, microangiopathic hemolytic anemia describes this, but what kind of conditions cause this kind of, can cause a microangiopathic hemolytic anemia?
DIC.
DIC.
Very good. DIC is one, yes. Okay, All right, so that is, at least that is a very good example, all right, of DIC, okay? And anything, and you know that DIC can be caused by very many conditions. Then you can get this kind of picture, like in hemolytic uremic syndrome, HUS, TT. You will come across those later as you go through your differential classes. Good. And then the final one down here, what do we have? Yes, TTP, thrombotic thrombocytopenic purpura. Very good. You do get your fragments and helmet cells. Excellent. And down here, the bottom right, what cells are those?
The chenocytes.
Okay, these are crenated cells, all right? Crenated cells and the echinocytes look very similar, and you can see these in which kind of conditions? You can see them in what kind of conditions? Renal disease is one where you get Barr cells or echinocytes. Crenated cells, you can also see them in liver disease. You can also see them in other conditions, or even when blood has not been stored properly, you can get crenated red cells. So this is showing you or highlighting the importance of the peripheral blood film. It gives us very useful clues, and when we combine this with the blood counts, we often can form some tentative or preliminary diagnoses. Okay. So then the final type of tests, the other type of tests we'll be doing will be establishing the exact type or cause of anemia. We may have to do hematinic levels, such as levels of ferritin, iron, vitamin B12, folate, red cell folate, bone marrow, iron, etc. We may need to do tests for the hemolytic conditions, and you'll have several lectures on hemolysis and the tests if we suspect it's sickle cell disease or spherocytosis, etc. And you may even need to do bone marrow evaluations. This is the bone marrow aspirate and bone marrow trephine biopsy. And this is where we look at the production of the red blood cells, which may be impaired as in megaloblastic anemia or the infiltrative conditions like the leukemias or your aplastic anemias. So once we've done, you've seen how we've done it stepwise. We've done our total blood counts and peripheral blood film. And from that now we'll know, yes, I saw sickle cells, I need to test for sickle cell anemia. I saw microcytic hypochromic cells, I need to test for iron deficiency, etc. And then finally, you need to establish what is the cause, okay? Because in order to treat successfully, you must treat the cause. So if I find there's iron deficiency, I need to treat the cause of that iron deficiency. If I find that there is an anemia, which I think might be due to chronic disease, I need to identify what is that chronic disease. The investigations, therefore, here may be simple to more sophisticated. You might have, and these will be very much guided by your history, your physical exam, and your hematological investigations. You may need to do bone marrow, as I said, examination, biochemical tests, microbiological or parasitological tests. You may need to look for those. Immunological, if it is malignant disease, you may need cytogenetic and molecular for your leukemias, for example. Imaging, you may, if you think there's a cancer, you need to do imaging, or histology, you need to do biopsies of masses, etc. Okay, so you now need, these are the tests to establish the cause of that anemia. All right. So in conclusion, we have seen that anemia is one of the most common hematologic conditions that you're going to come across. It is not a diagnosis. And therefore, even when it is a very mild anemia, you need to investigate As to the cause, you cannot dismiss it, that it is mild, it will go away. You need to investigate it. It is defined as the reduction of hemoglobin concentration to below the lower limit for normal, specified for the age, sex, and geographic location of the patient. The clinical features seen in anemia may be general and non-specific, and those are the general features, signs, and symptoms that I told you that will be seen in any anemia. Or there are also features that are specific to certain types of anemia, like I said, in iron deficiency anemia, you see chylomicria. In a hemolytic anemia, you may see jaundice, etc. Or they may be secondary to the underlying condition causing the anemia. So if somebody has a chronic inflammatory disease, chronic infection, or chronic heart disease, chronic renal disease, liver disease, etc., leukemia, whatever it is, that is where that falls in. And then the investigations should be guided by the clinical features and sign, and they should aim at establishing the presence and the type of anemia and determining the cause of anemia. All right? So with that, we have come to the end of the lecture. I will now stop screen sharing, and you may post questions on the chat box, because now I'll be able to see them. Okay. Any questions? And as I emphasized, that anemia is a condition that if you work in the hospital, you will find at least half of your patients in a general medical ward or a general pediatric ward will have an anemia of some sort. So it's a very common condition. And therefore, determining the cause is paramount. Okay. So, okay, very good. I can see there is lots of questions here. Let's start with what can lead to very low RBC and white blood cells with thrombocytosis. Okay. So you have low white cells and low red cells and thrombocytosis. It can be a combination of causes, because you can see two parameters are low and one is high. It is unlikely to be due to something that is affecting the total bone marrow. For example, it's not going to be due to like bone marrow failure. It may be, sometimes you see with iron deficiency anemia, you can get low red cells. Sometimes if there's something else on top, you might get low white cells, and that the iron deficiency anemia itself may be combined with a thrombocytosis. So you see, this one will not be a straightforward answer that it is only one cause. You may have several causes being present, okay? So low white cell and low red cells combined with the thrombocytosis is a mixed kind of causation that is present, okay? Often that will be present. Having an anemia with raised white cells and thrombocytosis, again, that may point to an iron deficiency. It could be a bleed, an acute bleed can lead to low white cells, and then you have a reactive increase in your white cells and your platelets. What is the difference between acanthocytes and echinocytes? All right, that is a good question. Now, acanthocytes, if you looked at those projections on the cells, an acanthocyte is when the projections are less than 8. So, and they tend to be quite irregular. Acanthocytes are very often seen in liver disease, okay? Whereas a crenated cell or an echinocyte, you have many projections on the cell. Like what we saw, that would fall into crenation or echinocytes. The projections were regular, and you could see they were regular. and there were more than 8, usually 10 to 12 or more. Echinocytes or Burr cells, echinocytes are also called Burr cells, the projection seems to be elongated. That is a fairly common feature of a renal disease, and you might see it as well in some other kind of hemolytic conditions, especially those that are associated with abnormal blood group. Okay, so it's more the number of projections on the cell that will give you the difference between acanthocytes and echinocytes. And when we come to the later lectures on the hemolytic anemias, we will be able to show you more images of that. When it comes to lower production of reticulocytes, it could be due to lack of response to erythropoietin or lack of its production altogether. Very good. Yes. If you have low erythropoietin, like you get in kidney disease, then your red cell production is reduced because there's not enough erythropoietin to stimulate it. So the low production of reticulocytes or low red cell production is related in that case to low erythropoietin production. Very good, Billy. What is bone marrow? Okay. BMTB is bone marrow trephine biopsy. Okay. When you come back, you will see there are 2 ways that we use to examine the bone marrow. It can be an aspirate or a trephine biopsy. Okay. And why is trephine biopsy done instead of just a bone marrow aspirate? Now, a bone marrow aspirate is we put the needle into the bone marrow space and we suck it out with a syringe. Whereas a trephine biopsy, we are actually taking a biopsy. It is a very thin core of bone marrow. That's why we call it trephine biopsy, but it is a biopsy. Now, the differences is that one will give us certain type of information. The trephine biopsy is excellent if we want to see if the bone marrow is involved by, say, a cancer. Like if there is metastasis to the bone marrow, we always recommend you do a trephine biopsy. However, we always say you should do both of them at the same time. Even for assessment of iron status, a trephine biopsy is considered superior to just the aspirate. So both give us complementary information. We will give you an in-depth talk on trephine biopsy and bone marrow aspirate, but those is why we do trephine biopsy. Sometimes when we are doing the aspirate, we're not getting particles, and therefore we need to do a trephine biopsy. To confirm a plastic anemia, we need to do a trephine biopsy. So we will tell you more about that. Okay. Somebody has asked for the slides. Yes, I will send you the slides. So the class rep can give me the class email so that I send it once. Does RDW suggest in full? What does allow RDW? All right. We have the normal RDW. The range is about 10 to 14. Anything lower has no significance whatsoever. All right. So there's no significance of a low RDW. I've never seen anything less than about 8 or 9. All that it just tells you is that your red cells are very uniform in size. Okay. What level of hemoglobin do you do to indicate a blood transfusion for a person who's anemic? There are very many considerations in this. We will consider what is the cause of the anemia. So if somebody comes with low hemoglobin, they have iron deficiency anemia, and it is not life-threatening, I will give them iron supplements. If they come with a similar hemoglobin and it is falling, then I may give them a transfusion because I'm worried that they may tip off into congestive cardiac failure. Usually anything below 5 grams per deciliter, you will want to transfuse. However, if it is somebody who has sickle cell anemia, they are usually at HB6. I'm not going to transfuse them if that is their baseline hemoglobin. Again, somebody may come with a hemoglobin of 9, but the rate of fall is rapid, and therefore I may want to transfuse them, whereas somebody else comes with 9 and they're stable, I'm not going to transfuse them. So it's not quite a simple answer as one would say, okay? But anybody with severe anemia and they're symptomatic, you want to transfuse them. And of course, you know, if somebody's going for surgery, the HB is 8, they may be asymptomatic, but because they need to go to surgery, the surgeons will say they want the HB to be 10. So that one you will transfuse. Okay, why we prefer hemoglobin over red cell in the definition of anemia. Very good, I'll repeat that again. Hemoglobin is a very good measurement. It's easy to measure, very standardized. And if the hemoglobin is lower than the lower limit, it indicates anemia. For example, in some cases of iron deficiency anemia, say you may have a low hemoglobin. The hemoglobin may actually say be maybe 10 times 10 to the 9 per liter. The red cell count may actually be within normal, all right? So that's why we prefer hemoglobin as opposed to red cell count in the definition of anemia, all right? Because sometimes you may have an anemia, but the red cell count is not low. And that's more so especially when we're talking of the iron deficiency anemias. I hope that responds to your question, Hanifa. Kevin, in instances where excessive IV infusion causes hemodilution, HB concentration will be decreased. Is this true anemia? And if it is, how do you correct it? Okay. Excessive IV infusion, especially with somebody who has a borderline hemoglobin status, yes. And indeed, like in anemia of chronic disease or anemia that develops over a slow period of time, you will find that the red cell concentration is low. And on top of that, you have a relative increase in your plasma, so that the anemia may seem to be even worse than if you didn't have that increase in the plasma, because the hemoglobin level will seem to be even lower, all right? Again, if you have blood loss, an acute blood loss, before the hemodynamic changes take place, the plasma volume increases to compensate. If I took the hemoglobin level, you will see that the hemoglobin level may still be within normal, all right? And that's because the hemodynamic changes have not taken place. The compensatory hemodynamic changes have not taken place. Okay, so that's important to consider. If blood or dry taps have occurred on 2 different occasions with bone marrow aspirate, a trephine biopsy should be performed. Ideally, we shouldn't be waiting for 2 different occasions. And indeed, in very good, and actually most centers, they recommend any indication where you're doing your bone marrow aspirate, you should be also doing your trephine biopsy at the same time. And it will prevent this doing the bone marrow aspirate, you get a dry tap, you return, you get another dry tap, you waste a lot of time. So we really usually will recommend that bone marrow aspirate and trephine biopsy should be done in the same setting. Okay. Hemoglobin of 16 is normal, but MCH and MCV are high. What does that suggest? Okay. Now you see, sometimes we may get conditions such as alcoholism, all right? if somebody is taking alcohol, in the early stages before they start decompensating, alcohol causes you to have a high mean corpuscular volume, all right? Again, drugs such as antiretroviral, there are some anti-cancer drugs like the methotrexates. They can cause your mean corpuscular volume to go high and your hemoglobin will still be within normal. But as the condition continues, the hemoglobin level will again start to fall, all right? So those are some of the conditions that you can have a normal hemoglobin with a raised MCV and MCH. Another scenario, hemoglobin of 16 is normal, but MCH and MCV are high. Okay, all right, that was a repetition. MCH and MCV are low. Again, you may get a normal. And then if it is like some conditions where you might have microcytosis, especially some of the abnormal hemoglobinopathies where the hemoglobin tends to hang on to the oxygen, okay? You might get normal hemoglobin with a low MCV and MCH. Again, in your beta thal minor, your abnormal hemoglobinopathies like your beta thalassemia, the trait will be associated with a hemoglobin that is within normal, but your mean corpuscular volume and your mean corpuscular hemoglobin will be low, all right? Again, the hemoglobin may not be as high as 16. It may be sort of like borderline normal hemoglobin, all right? But sometimes with the abnormal hemoglobinopathies, you can still see pretty high HB. And in these ones, you will also find that the red cell count will tend to be elevated as well, okay? Again, when you have your polycythemia, you will come across your polycythemia, which is a neoplastic, well, not always neoplastic, but where you have an increase in the red cell mass. If you have polycythemia and then you develop iron deficiency, at the same time, your hemoglobin may still be normal, but your MCV is low and MCH is low, all right? So these are some more complex conditions and not very simple due to one kind of one pathology only, okay? All right. Yes, so I think that's done with the questions. Okay. All right, so if you don't have any other questions, then you will please try and practice when you go to the wards to try and see if you can sort of look in the history and see what is the cause of anemia. If there's an anemia that is present, it'll give you good practice. And when you come for your clerkship, you will also do further work on anemias. Okay, all right. Any other questions? Okay, so that comes to the end of our lecture. Thank you.
I can